who's an associate professor in infectious disease modeling at the University of California, San Diego. She specializes in models of hepatitis C amongst injecting drug users, many have sex in men, and other risk groups. And she'll be presenting on hepatitis C, where are we today, and unmet treatment needs.
Thank you, Peter. These are my disclosures. So hepatitis C, where we are today. Well, there are roughly 100 country-level estimates of the prevalence of anti-hepatitis C virus in the general population, and one of the main take-home points is that there's marked heterogeneity between countries, and actually this heterogeneity exists both between and within countries. So approximately 70% of the estimates that we have report a general population prevalence of less than 2%, but some have very high prevalences of upwards of 5 or above 10% in the general population. Now, the highest burden of disease of hepatitis C is among low to middle income country settings. And this is shown here where the size of the country represents the number of individuals with hepatitis C exposure. So this analysis found that approximately 3/4 of individuals infected with hepatitis C are located in middle income country settings. However, there's a lack of consensus on the number of people with hepatitis C infection globally. So this is a slide that shows the number of citations of different global estimates of the seroprevalence of hepatitis C, and you can see that the literature ranges from estimates of as low as 110 million individuals to upwards of 180 million individuals, so there's substantial uncertainty in this estimate of global burden. Now, until recently, the mortality due to viral hepatitis was relatively unclear because the global burden of disease did not actually attribute mortality specifically to viral hepatitis. So instead, they listed, these are the 10 leading causes of mortality globally, and they actually listed deaths due to cirrhosis, which came in 12th, and hepatocellular carcinoma, which came in 16th in the 2013 global burden of disease. Now, when we actually did a recent analysis where we attributed the deaths due to viral hepatitis to these two causes and we grouped them together, we were able to regroup and find that in this case viral hepatitis actually ended up within the top 10 and in fact was the 7th leading cause of mortality within the GBD in 2013, and that was above HIV, tuberculosis, and malaria. Now, within viral hepatitis, roughly half of the deaths are attributable to hepatitis C, with an increasing number over time, and an estimated 700,000 deaths annually related to hepatitis C. Now, as you've been hearing today, the hepatitis C treatment landscape is rapidly changing, and the advent of increasingly tolerable, effective, short-course hepatitis C direct-acting antiviral therapy has really improved the outcomes and potential ability to treat for this disease. And there's renewed optimism that more individuals can be treated. As you can see from the slide, despite these increases in treatment efficacy that we've seen, there are still very few that are being treated, with an estimate of 95% of infected people not receiving treatment in 2012 globally. Now, if you look at a country level, you can see that, again, these treatment rates are low, so with most countries treating less than, say, 2% of those who are infected, but diagnosis rates are similarly low, with less than half of individuals with hepatitis C diagnosed. And these rates are particularly low in low to middle-income country settings. Now, one of the other barriers for increased treatment scale-up worldwide is the extremely high cost of the new direct-acting antiviral therapies. So the high cost of these therapies, even in high-income settings, is likely to prevent many from accessing treatment. And even in low to middle-income country settings where these treatments are available at a reduced cost, treatment for all is not affordable. Now, there is optimism that these drug prices will come down, especially because of recent analyses which have shown that the minimum production cost of these drugs is really only around $100 per treatment course, so hopefully there's room for a change in the future. So what is the unmet treatment need? In other words, who needs treatment? Well, all the major international guidelines recommend that treatment, it should be recommended for all persons with chronic hepatitis C infection. But because of the high costs of hepatitis C treatment, there's increasing need for prioritization strategies. So in the US, the guidelines assign the highest priority for treatment for those with the most advanced liver disease stage, so F3 or F4 fibrosis. And by contrast, those with less advanced disease, such as F2, are assigned a high priority, but not the highest priority. Other individuals in that high priority category are those co-infected with HIV and hepatitis B virus, as well as a few other categories you see here today. Now, interestingly, the guidelines also make note of the potential prevention benefits and additional benefits of treating those who are at risk of transmitting to others, such as people who inject drugs, men who have sex with men, and prisoners. However, they don't actually assign a priority ranking to this group. They just note the potential prevention benefit. Now, in Europe, the guidelines are generally similar, although there are a few small differences. Again, treatment is prioritized for those with most advanced liver disease, so for those F3 and F4 and decompensated cirrhosis. Treatment is also prioritized for those co-infected with HIV and hepatitis B. And as of 2015, they actually explicitly prioritize treatment for individuals at risk of transmission regardless of their disease stage. However, this recommendation is assigned a grade of B1, which it means that it's a moderate evidence quality, and that further research is likely to have an important impact on their confidence in that recommendation. These guidelines similarly say that treatment is justified for people at F2 disease stage, and for those at an earlier disease stage, or F0 or F1, informed deferral can be considered in this case. So prioritization is occurring in the guidelines, but is it being implemented in the real world? And the answer is yes. So this is a study that recently came out in Annals of Internal Medicine looking at the Medicaid reimbursement criteria for sofosbuvir in the United States. This slide has been shown earlier today. And it showed that there is reimbursement only for F3 and F4 in most states. Some are reimbursing F2 to F4, but most are F3 to F4. Now, disappointingly, the same study also looked at any criteria for required abstinence from drug and alcohol, and they found that the majority of states, in fact 34 of them, did have restrictions and required abstinence for drug and alcohol for a certain amount of time, as shown in this slide. And this is actually against the current guidelines, which again recommend treatment for those with an ongoing risk of infection, and particularly people who inject drugs. So even though the guidelines are recommending treatment and saying that injectors should be eligible, there are restrictions being put in place. So why is treating injectors so important? Well, if you don't treat those who are on risk of transmitting the virus, then you aren't turning off the tap of the epidemic. And so we've used dynamic transmission models to try to understand the potential benefit of treatment at a population level. This is work that we performed in modeling in Melbourne, Australia, which looked at the impact of modest and achievable levels of treatment for people who inject drugs and the impact that it could have on the hepatitis C prevalence in this setting, which, as you can see, where roughly about 50% of injectors are chronically infected with the disease. So even in Vancouver, here we did a similar modeling exercise. We were able to show that treatment as prevention may be feasible and have substantial benefits, although in this setting, the higher prevalence of disease, with about 65% of injectors chronically infected, or about 85% of them with antibody exposure, because of this high risk of infection and reinfection, the prevention benefit is dampened slightly. But still, there could be a substantial prevention benefit, which could ultimately result in control of the epidemic. So I think the key question is the prevention benefits are really determined by who you treat. So what kind of benefit do you have depending on who you're treating? Well, we know there will be no prevention benefit if treatment is denied to those at risk of transmitting the disease, which we can see already is happening in certain scenarios. And we know there won't be any prevention benefit if treatment is prioritized to those that are unlikely to transmit the disease. So we got to this, perhaps we might be reaching this trade-off point where right now we're prioritizing treatments for those that have a more advanced liver disease stage, but those individuals who are older and potentially may not be the ones that are most at risk of onwards transmission. Whereas those who are at risk of transmission may be younger with less advanced liver disease. So if we're prioritizing treatments for liver disease stage only, we may have less of this prevention benefit. So there may be somewhat of a trade-off. So Prioritization is occurring, and there is increasing need for informed and evidence-based prioritization strategies. Now, economic analyses, which look at individual benefits only of hepatitis C treatment, support prioritization by liver disease stage. It's best to prioritize treatment for those who are most at risk of progressing to end-stage liver disease and death. But what happens if we consider the potential prevention benefits as well? So we wanted to look at that. Now, in order to examine this, we needed to use a dynamic hepatitis C transmission model. And I really want to emphasize this point. If we want to look at the impact of treatment as prevention, we need a model that's looking at the epidemic and modeling it mechanistically. And we need a model where an individual's risk of infection is related to the background prevalence of disease, which can change over time. So we're not fixing incidence. Incidence can change as we scale up interventions, as a person's risk changes through time. So we use this dynamic model, and this is just a model schematic from one of our analyses where we're modeling hepatitis C transmission, in this case among people who inject drugs. And it's an open model. Injectors are continually entering as they start injecting, and they're exiting through cessation of drug use or death. And they can become infected. And as I mentioned, the risk of infection, the incidence of disease, is related to the background prevalence, which can change over time as we increase treatment or we increase our other interventions scale up. So those who are chronically infected can be put on treatment, and if they achieve sustained viral response, then we allow for reinfection, and we make no assumptions about any change in risk behavior. So the risk of reinfection is the same as primary infection. And we use this type of model to really evaluate the dynamic effects of scaling up of treatment as prevention. Now, in this particular prioritization analysis, we've already used this type of model to say whether hepatitis C treatment and achievable levels could have a prevention benefit. But in this analysis, we wanted to ask the question, should injectors be prioritized? So treatment may have a prevention benefit, but should injectors be preferentially treated given their risk status? So this analysis ranks the order in which people should receive treatment. It's not evaluating whether a specific drug is cost effective. It's saying if we have a limited availability of treatments, who do we allocate it to first? We use a dynamic economic model of hepatitis C transmission. We also include disease progression through the liver disease stages and follow injectors through their life course so we can look at their long-term disease outcomes. And our baseline is that we treat everyone once they reach cirrhosis. So everybody who reaches cirrhosis is offered treatment in this model, and then we compare prioritization of interferon-free treatment at earlier disease stages and by risk status. A few more details, we use a UK healthcare provider perspective, and we look at 3 settings of chronic prevalence among people who inject drugs, a sort of low, medium, and high, 20, 40, and 60% prevalence, chronic prevalence. And we look at a generic treatment, 95% SVR, 12 weeks, and we look at long-term health utilities and quality-adjusted life years and costs. And we rank our groups by using the net monetary benefit, which is calculated here. Now, I know this slide is a little bit busy, so I'll talk you through it, but basically, it shows you the ranking for each of our prevalence settings. And the take-home point is in our 20% and our 40% chronic prevalence settings, our low and our moderate settings, it's actually, from an economic point of view, best to prioritize treatments first by risk status. First, treating those with an ongoing infection risk regardless of disease stage because of the substantial prevention benefits. So in fact, at the lowest prevalence setting, 20% chronic prevalence, treating 1 injector prevents 2 new infections. So you have a really substantial prevention benefit. Now, only at a very high prevalence setting, 60% chronic, that's about 80% antibody prevalence in this injector setting, does the prioritization strategy change? And in that case, it's actually best to prioritize by disease stage first. So the first people you treat are the most advanced with moderate disease, and then you treat the milds. And this is because of the very high rates of reinfection in this setting, which dampens the prevention benefit, as I mentioned before. Now, importantly, these relative rankings hold regardless of the cost of therapy. Remember, we're not talking about whether a therapy is cost-effective. We're saying with a given therapy, really no matter what the cost is, how do we prioritize distribution of it? Now, I just want to caveat, we're not recommending prioritization or rationing, but we're trying to answer the question, which really is a real question and a pressing question now, that if we need to prioritize, who should we prioritize to? And our analysis shows from a cost-effectiveness viewpoint that prioritization should consider disease stage and current risk status. And in fact, this prioritization strategy will change depending on what type of epidemic scenario you're in. So of course, cost effectiveness is only one of many important factors involved in clinical decision making. Additionally, the rankings may be different in different settings with substantial transmission via other, for example, non-injecting routes where treatment of non-injectors may have some prevention benefit. But I think the take-home point, I hope, is that modeling can help inform these strategies and form the evidence base for prioritization. So back to the unmet treatment need. This slide is courtesy of Stefan and Victor at the WHO, where they estimate about 130 million persons with chronic hepatitis C infection need treatment. Now, if we're prioritizing to those with F3 and F4 fibrosis, then about 26 to 30 million individuals would need to be prioritized for treatment. But if we also include people who inject drugs with chronic hepatitis C, that adds about another 5 to 12 million potentially, most of whom will be at earlier fibrosis stages. And of course, there are 4 to 6 million individuals with HIV hepatitis C co-infection, some of whom will be in these categories that I've already mentioned, so there may be some overlap. So in conclusion, I would say that there's a high burden of disease from hepatitis C, about 80 to 130 million chronically infected individuals worldwide, but there's substantial uncertainty, and we need better surveillance to really firm up these estimates. Hepatitis C is an increasing cause of mortality worldwide with about 700,000 deaths per year. Happily, there's highly effective direct-acting antiviral therapy for hepatitis C, but this therapy right now is expensive and treatment rates are low globally. There's a desperate need for informed prioritization strategies, and I think mathematical modeling can really be of help here. And finally, there's increasing interest in hepatitis C treatment as prevention. But the work I showed you today was modeling work, and we really need empirical studies testing treatment as prevention in the real world, and we need lower costs enabling scale-up of treatment so that we can see these population-level benefits. I'd like to acknowledge my collaborators and our funders. Thank you.